some people were on that. I think I saw Austin, but not Alec on the Alec, were you on that case?
Yep, I was there.
Well, thank you. Thank you for updating us. Sharmin, Mike to you. A man of few words.
I'm sure it was incredible because all your discussions are amazing. And it's like so cool that you guys discussed in Spain. That's awesome. Did you discuss in Spanish? I would be very impressed if you guys did
Oui,
that.
oui, je parle espagnol.
It's okay. I hear in Europe a lot of people are multilingual anyways, so it's great. Big shout out to Masa and Minahil for doing teaching point and scribing, and Jazz, the one and only, is presenting a case. Be kind to us. I'm still working through my coffee. How's it going, friend?
I'm doing well. I'm gonna call out Reza because we were chatting behind the scenes and he forgot that I was Canadian, but that's not new. Reza forgets a lot of little details about me.
Hey, to stand up for Prof. Res, he remembered you were a goalie, so that is impressive.
See, this is why you're an honorary Canadian, Charmaine, because you're very nice.
Hey, I'm gonna hold Canada to that, okay? All right, everyone. If you can get the board up, we can get started.
All right, so this case is a case I saw in December. Was a pretty special case for me. So I'm going to start off with, so there's total of 7 aliquots. The seventh aliquot has the final diagnosis, but just to, keep in perspective, is the last 3 aliquots are kind of more smaller in size. I'm going to start off just generic because I think it'll be good as a refresher for a broad approach to a common complaint. So the first aliquot is a 41-year-old female who presents to the hospital with a headache.
Wow, what a start, eh, Charmaine? So when you go out here to approach headache, you have to be very systematic. And headache, it's so interesting. Like I'll tackle this aliquot pretty quickly. Um, the one piece of information that Jazz hasn't shared yet, which he will share, is the tempo. So right now we're just approaching headache as a broad category. And really, Aaron taught me to put it in 3 buckets. And really, it starts out with 2 buckets, and then the second one becomes 3. But let me clarify what I mean by that. The number 1 bucket is this a primary headache? Right? By far, if you were a betting person, you would bet right off the bat that this is a primary headache. And many of us experience that. If you take Charmine's coffee away for a day, she will definitely have a migraine or a headache.
I actually don't, which is
Oh,
fascinating.
wow.
Yeah, I know. It's my superpower. Thank you very much.
Charmise, you're supposed to be Canadian and kind and agree with everything I say. It's been revoked, your honorary Canadian status.
Hey, you came after my coffee.
But the primary headache is migraine, tension headache. These are the primary headache syndrome. And really, our job is to know when we should deviate from the common. If I have a headache and I feel fine, I might take an Advil, and that would be the end of it. And that's when you get to the second category. And the second category is placed in 3 buckets, not just one, 3. One would be something happening external. So if a patient has acute angle closure glaucoma, they might have a headache. If they have blurry vision, they may have a headache. I had my tooth extracted, my wisdom tooth last week under local, and the dentist said, "Hey, Reza, any medical problems?" I said, "Just alopecia and obesity-induced GERD, and I'm on omeprazole." But when he removed the tooth, Charmine, I had a headache. If you have something going on in the neck, it can cause a headache. So it's really important to consider, like, just look at yourself in the mirror. Anything happening here can cause headache. Then the next category is systemic issues. Like, how often have you taken care of patients with the flu, with something happening within, like a fever, and they have a headache as a bystander? And then the third bucket is the one I think, Sharmin, that we all consider, because we say, oh, is it a primary headache or is it a secondary headache syndrome? But if you just do that, you're going to miss external stuff in the face and systemic stuff manifesting as headache. And that category is internal, inside the brain. And then you can just think about the compartments of tissue. The brain parenchyma, you can have a tumor. The vessels, you can have GCA. The subarachnoid space, you can have a bleed. But you can easily see how that category is stuff like meningitis, encephalitis, etc. So when do we make the transition from like primary headache to being concerned for secondary? And that's really the Snoop mnemonic. I don't remember all the words, but what I do remember, if it's severe, sudden onset, worse headache, focal neurologic deficit, positional, happening at night, this kind of stuff. Any of those red flags pushes you to consider that secondary headache syndrome category. Sharmin, before we get the next aliquot, can you maybe summarize what I just said, but in a better, like just very like a nice quick summary for the audience?
You're brilliant. And we definitely have different definitions of obesity, but we can talk about that another time. But no, I really, really love that, Prof. Rez. So thank you for teaching us that. Yeah, when it comes to like headache, a lot of the times, most commonly are primary headaches, like migraine headaches, tension headaches. And then oftentimes, like in my world of like hospital medicine, I don't deal with that as much. Oftentimes when I come in, it falls into the other bucket that sometimes I like to think about as Prof. Rez was like is exacerbation of something going on. Whether it's an exacerbation of something going on like in your head, face, necks, kind of like local structures next to your brain, exacerbation with systematic issues that is leading to having a headache as like, someone presenting with like sinus tachycardia. There's a reason why them to be sinus tachycardic. They can have a headache that's not related to the head itself, but a manifestation of somewhere else in the body, or is it an intracranial process? That was awesome, Prof. Rez. I love it. Okay, Jazz, back to you.
That was amazing. Learned a lot, including that by comparison, I'm morbidly obese, apparently. Um, and then second aliquot. So patient basically tells me that it's been about like a month where her headache has been kind of like intermittent. It would come and go. But it was a past week where she noticed that it became more constant and like not as intermittent as the normal pattern that she attributed to. She says that the pain is located more occipitally in the back of her head, with occasional radiation of pain to her like the cervical spine, but does not radiate down to her arms or anything like that. And for the most part, they have not been severe. She also says that, like, for the past month, she has cervicalgia and basically was diagnosed by her chiropractor and was getting some treatments for that, in addition to taking acetaminophen and ibuprofen, in addition to cyclobenzaprine, which has been helping. But for the last couple of days, despite taking those medications, she still continued to worsen in terms of her headaches. She denies any focal extremity weakness, numbness, facial droops, slurred speeches, vision changes, dizziness, no falls, no ataxic gait. And she denies any dyspnea, no chest pain, no fevers, no chills, no recent sore throats or viral infections. The only thing that she endorsed was like some fatigue in the past, few months, to be exact, like about 6 months. But other than that, like nothing new. And kind of felt like it was just the main reason she came into the hospital was that the headache, despite taking Tylenol and Advil, did not get better in the last couple of days. Her past medical history is notable for anxiety, and she takes Xanax PRN. She has this history of acid reflux, but apparently not obesity induced. She has this history of cervicalgia, and she does have remote history of migraines. This is just based off chart review. It seems like she's been pretty healthy, but over a year ago, she was having some vague abdominal pain, and a abdominal ultrasound did note a hepatic lesion in the right hepatic lobe. That's part of her past medical history. Medications that she's on is a PPI, cyclobenzaprine, acetaminophen, and ibuprofen as needed, Xanax as needed. There's no relevant surgical history. Social history, has not had any travels recently, lives with her husband, has 2 dogs, no allergies. And I'll stop there for the end of the second aliquot.
All right. Thank you so much, Jazz. Maybe I'll tackle a little bit of an HPI and then pass the mic to the Prof. Rez to keep us going. So kind of sounds like, she is 41 years old, coming in with kind of progressively worsening, kind of like head and neck pain is like how I would phrase it. Cervicalgia is a very non-specific term. To me, it just means like she has neck pain, and the etiology of it is like a little unclear to me as it's an umbrella term. It's not like a specific diagnosis. So that is like something to keep in mind as we move forward. Whether in the beautiful buckets that Prof. Rez says, like where this headache lies, I think the fact that there is some neck pain associated with it makes me think like, hey, is it actually like more neck and shoulder pain that is causing a headache, and whether it's like a sequel of a headache? But again, like you want to hold the secondary causes, still hold on to them because we don't have enough clarity to move forward. For me, like oftentimes, like as a non-neurologist, primary headaches when people present to the hospital becomes a diagnosis of exclusion. So in my thinking, to make sure that I'm not missing any secondary causes of the headaches. The other thing that is also notable is that if people are getting treatment for a secondary headache, what the treatment are they getting and what is it targeting, right? Especially if they're getting treated outside, any steroid injections. Oftentimes people that can be a nidus for an infection. Ibuprofen, Tylenol has some anti-inflammatory effect. Like if it's like a more muscle and like muscle strains, then oftentimes cyclobenzaprine would be helpful. So whatever she's having, most likely has some component of muscle spasms. Now the other things, so always we want to make sure that they have no whiplash, no trauma. Sometimes hand ergonomics at work tend to be a very common cause of neck and shoulder pain. So again, common things being common, those are the things to value. So for me, anatomy is really good framework to tackle these things. And oftentimes when you're one area is on fire, your neighbor is. So neck, shoulder, they're all next to each other. So trying to figure out and isolate where the problem is, doing a good shoulder exam, doing a good neck exam would be really helpful in making some progress. As well as kind of thinking about again anatomy, scarring with the skin, exhauster. She's too young for that. Muscles, vascular involvement, and then you get to the C spine, which I personally am scared of, especially because it's important area. So thinking about whether it's at all vertebral or spinal cord is affected, I think it is definitely your biggest no misdiagnosis, just because how important of a structure it is. So that's kind of how I think about it. Again, isolating different compartments, thinking through which one could be potentially affected, and then putting it more in a systemic context to see if there's if it's just isolated to this region, or as Prof. Rez mentioned, is it a representation of a more systemic issue? Prof. Rez. Oh.
Sharmin, that was so beautifully said. I love that approach. And I'm going to keep it really authentic here. Truthfully, so far, nothing in the HPI or the past medical is a reason to admit this patient. It's a subacute intermittent headache, no focal neurologic deficit. So I'm still waiting to see what was the red flag that prompted the ED to request admission to the hospital. I'm not going to even comment on the vague abdominal pain because I think that would be inauthentic to try to link the two together. But we'll see how the case unfolds. Nothing from the past medical is concerning to me. The only thing that maybe makes me a little worried is anxiety. And the reason for that is people that are anxious, oftentimes clinicians and providers erroneously dismiss their concerns due to their anxiety. So for me, anxiety is just a reminder, hey, Rez, don't just say, hey, it's because they're anxious and they're nervous. Like you have to remove that and take it at face value. Mike, back to you, Jazz.
Great discussion. I just want to clarify. She hasn't had abdominal pain for the past year, but she did have abdominal pain a year ago, which had that finding. Just wanted to clarify that. So third aliquot, vitals, blood pressure 120/90, heart rate was 84, not tachypnic, respiratory rate was 18, afebrile 98.1 degrees Fahrenheit, and was sat 97% in room air. On exam, she was generally anxious appearing, but outside from that, it was a pretty benign exam. So regular rate and rhythm, clear to auscultate bilaterally. There was no tenderness to palpation in the abdomen, no distension. Neuro exam, cranial nerves from 2 to 12 were intact. 5 out of 5 strength of upper and lower extremities. Sensation was intact. There was no ataxic gait. I examined her neck pretty thoroughly, and there was really no lumps, bumps, or anything like that. No tenderness to palpation. Her neck range of motion was, it was okay. It was, you can tell that she still had some stiffness from the vague diagnosis of cervicalgia, but other than that, nothing much that stood out from the exam. Initial labs, she had a mild WBC count of 13.1. She had a hemoglobin of 10, platelets of 150. Her UA was sent in the ED, which was normal. And a comprehensive metabolic panel was all within normal limits. There was no abnormalities. To answer your question, Reza, why ED admitted her, they did a CT head in the ED because of the headaches, and it was basically normal except for a pineal cyst measuring up to 1.4 centimeters with possible mass effect to the adjacent tectum. Tectum. I don't know how you pronounce that, but tectum. And then ESR was mildly elevated at 57, and a CRP was normal at 0.7. And that's the end of this aliquot.
Boy, well, first of all, Jazz, man, you're an expert presenter, just like so calm, collected, giving us the salient stuff. And it's just awesome to see your growth as truly from your early days to now. It's incredible. And I'm going to be authentic here. I'm going to need Charmin's help. Like I really am. And I think, Charmin, when I look at this, I see that the hemoglobin is low, the platelet is slightly low, and the white count is slightly elevated. It's not normal. This is an abnormal CBC. And this is when I would go on Epic or whatever records you use at your hospital and look at the prior values to see what the trend has been. Though it's not easy for me to link the CBC necessarily to the chief concern of headache. I've never really dealt with I actually don't even know where the pineal location is. I've read it before, I've heard it before, but 1 centimeter seems quite large. And the question then becomes, is that the cause of her headache? And how confident are we that it's just that cyst? Because by definition, cyst versus abscess versus mass has to do with the wall and the content. But we all know that CT scan isn't the best at evaluating the brain parenchyma. So I would be doing one and two things. One is I would be getting an MRI with gadolinium of the head, and I would just include the neck because of this complaint of neck pain. And then two, I would be either GPTing and talking to our neurology colleagues to be like, hey, what is this a distractor? Is this the cause of headache? What else do I need to do to further investigate this? Because really, I think the question we're left with here, Sharmin, is whether this thing that we've identified on CT scan, is it causal or is it just an incidental finding? And I don't know the answer to that, but what I know is that it seems a bit large, and that I would want an MRI to better evaluate to see if there's any other lesions and to better characterize the lesion that was detected on CT, which is inferior to an MRI for evaluating the brain parenchyma. Now,
Yeah.
that's
Oh my gosh, I love your authentic thinking preference. Is the absolute best. I totally agree. I think like I'm also not convinced this cyst explains her presentation. And I think like it's just like more like closer to midbrain than to the occiput, but somebody please help us with the location of that. So I just not 100% sure. But this is where Google becomes really helpful.
where's Robbie when you need him?
Exactly. Where is Jiha? Uh, but yeah, I totally agree with you about like keeping it separate and working that up. The one thing that I was kind of reflecting on, if I was like seeing this patient in the ED, although like a 1 month of intermittent is not consistent, but I had like a couple of patients who uh, who presented this way that ended up having like cardiovascular issues that is with kind of their anginal equivalent, and they had like a really bad multivessel disease. So that is like also another no misdiagnosis for these patients, or tend to be like their cardiovascular system. And I had a patient with an NSTEMI that just presented with like kind of the constant like shoulder pain, and it turned out to have like unstable angina with like an LAD lesion that they ended up sending. So that is also again like maybe is a recency bias, but that's something to consider in patients who are coming in with kind of like vague symptoms that can happen. But and then that's the other thing about like kind of the leukocytosis. This patient's like a little bit inflamed, whether that is an infectious etiology, and with like a little bit of a cyst, is that at all an abscess of some sort? So and at least like I would get a blood culture, like low grade bacteremia. It can happen. And yeah, I agree with the hemoglobin drop as well. Like, I'm not sure if this is like, still a menstruating woman who has like some iron deficiency anemia, the delta is going to be really important. And whether that is like also a noise or signal, I'm not sure. So I think like again, separating out the headache, the cyst, and kind of like the hematologic abnormalities, and see what it comes out. I really like the preface about you saying to include the neck. The number of times like you find pathology in the neck that you were looking for, it's quite impressive. So especially if the patients have symptoms there, to investigate that. I think that's a great idea. But yeah, Prof. Rez, I'm still looking for something to define, help us with the problem. Anything else to add?
This is why I love co-discussing with you, Charmaine. Like, I love the idea of blood cultures, and I love how you said hematologic, cyst, headache, but it's unclear how any of this is related. And we're just going to need more information. But that was a great pickup on the inflammation that I overlooked. Thank you. By the way, I'm going to have to break off for 5 minutes, but I'll be back in 5 minutes.
I'll try not to burn down the house. See you in a bit.
I expect you to have the diagnosis by the time I get back, Dr. Shikhachian.
Yes, sir.
All right. Let me get to the next aliquot here. Fourth aliquot. So blood cultures, no growth to date. Interestingly, the MRI head was completely negative. Did not show any pineal gland cysts or anything like that. There was no infarctions. There was no any enhancements anywhere. The CT abdomen pulse was also done just because of this history of this hepatic lesion, and it just showed a small benign appearing low attenuation and that is unchanged from prior. And the radiologist commented it was likely a hemangioma. Chest X-ray was done as well and was normal. And so, you know, this is when I saw the patient. So when I saw the patient, the MRI was already done, but it was still pending the read. And it was this lady was admitted overnight. I went to go see her, and I go in, and then the sign out that I had was, if the MRI is negative, this patient can go. This is likely, something that can be followed up outpatient. So I go into the room just to kind of just clarify how things are going, and just get some more collateral from the HNP that I read. I go into the room and she's just crying. And it's like, doc, like, I know you're probably going to discharge me, but I'm not usually like this. I'm a hardworking person, but for the past couple of months, I'm taking naps halfway throughout the day. And these headaches are just something that are just have for the past couple of months have just been like intermittently of a nuance, but for the last couple of days, I've never felt like this in my life. Um, and I just feel that there's something wrong with me. And I guess my next question is, so this is the end of the fourth aliquot, but my question would be, what would you do in this situation?
Wow. This is tough. I'm so sorry, patient, because this patient is like clearly suffering. And there is something to what we all learned in medical school, that patients know best. And if this patient is telling you, hey, there is something really wrong, there's something wrong, period. And our job is to figure out we're not missing anything. Um, so I would take her concerns seriously, and I'm also lucky enough, to be honest, to practice in a setting where I don't have as much pressure to discharge someone if I don't think they're medically ready. So um, this is a patient who is having worsening headaches for the past month to the point that is affecting their daily life, right? She needs to take a nap. She is not able to do the things that she needs to do. So this is a debilitating headache. And our job is to at least like try to have a reason as to why this patient is suffering. And while so much of this, you're right, could happen in an outpatient setting, she's here now, and see how much progress we can make for her. So I think what I would do here is that a couple of things. I love to talk to radiologists. So there is this discrepancy with the head CT and the MRI. So just making sure, again, our incredible colleagues, radiologists, are also human. They can miss things, they can overcall things. So a lot of the times going down and truly making sure there's no abnormalities in the MRI would be really helpful. The other thing is to think about like whether, as we focusing on like the secondary cause of the headaches, thinking about like, are we dealing with a primary type of a headache? Are we dealing with like something like some like a migraine is probably a little less likely by the cluster headaches of some sort. I am like getting neurologist help would be, I think, really, really helpful to make sure like we're not missing a primary headache. The other thing to think about is that, are we dealing with an intracranial process that just doesn't show up in an MRI? So are we dealing with like kind of a chronic meningitis type of a picture? Are we dealing with the elevated ICP type of picture? Like that, like whether it's like the headaches are like positional or not would be really, really helpful to know. So Profres, basically what happened is that MRI was negative, actually didn't show any pathologist. Jazz and the sign out was to Jazz that if they go in, if the MRI is negative, the next morning the patients get ready to discharge. And when Jazz sees the patient, she is like incredibly distressed that she about the severity of the headaches that's interfering with her life. She's crying, unable to do the things, and she's really worried about like being discharged. So the Jazz's question was like, what would we do in this situation? So just to summarize, I would take her concerns seriously. I would ask neurology for help to make sure we're not missing any primary headaches, and also thinking about like whether there is any diagnoses that we are missing, which is like, do we need to LP this patient with her? What are we dealing with, an increased ICP of some sort? But I do think like at least getting neurology to see her would be like a good first step. Profess, what do you think?
I love that. And the point you made, Charmaine, was an important one. Like MRI negative headache, knowing that that has its own differential diagnosis. So I only have like two thoughts to add. One is like the threshold to just treat for migraine should be really low. It really should be because it's so common and it presents in so many ways. I once had a patient with abdominal pain who also had headache and had actually abdominal migraine, and neurology just started the anti migraine medications, and the patient improved and regained 80 pounds of weight loss. So that's one comment. I think like the threshold to just treat should be very low because then it's a diagnostic test too. So if you give her anti-migraine medication and she's much better and everything resolves, then you have more, weight. The other thing I'll say is that in that MRI negative category, we have to realize that the MRI wasn't an MRV, and sometimes you can get venous sinus thromboses, and she is sort of the right age for that. I don't think she's on any medication that increases her risk, but I think those are the two questions. Are we dealing with like a venous thrombosis? And whether to do the LP or not, that's a little difficult, honestly. Like I wouldn't rush to do an LP unless neuro had concerns for that. So authentically speaking, I think an MRV, MR with venous phase for a thrombus, and then neurology to see like what else are we missing here.
Awesome. Great discussion. So, just providing some context. So, occasionally I also work at a rural hospital that's about like 45 minutes outside of the city. And that's where I was working when I saw this patient. So, unfortunately, we don't have neurology. We have teleneurology, but we don't have neurology in-house immediately. And even radiologists are remote radiologists that we can't really get a hold of. So I'll give you the fifth aliquot. I looked at her, so she was a relatively healthy person, like, she, had no other concerns. I looked at her back, her last CBC, which was a year ago. And at that time, her WBC was 8, her hemoglobin was 14.8, and her platelets were 241. And, her LDH came back at 396. And I'll pause here before I give you guys the sixth aliquot.
Sharmizi, let me give you the mic. I'd love to hear how you dissect this. But I just want to make this comment, like the trend matters. Like Charmin said, and I said, like looking at the prior values matter big time.
Yeah, interesting. So she's having at least like worsening anemia. And I think like with the LDH, again, like I'm a true CP solvers human that I love the Venn diagrams, right? So like with the LDH and there is like that overlap of like LDH and anemia. And I think two things that comes to mind, hematological malignancies and also like hemolysis are the two things that I often think about. And if you want to loop into leukocytosis, then if we always like think about it as like stress response, neutrophilic response, but like what is the diff breakdown, and if there's like more lymphocytic predominance or something else, are we dealing actually with the hematologic malignancy? And this is why this might be like a systemic presentation. Again, like we don't see any involvement yet of the brain that we can like link it to headaches. However, these things can be subtle. But I think what I would do is like then focus my thinking on the hematologic. So I really don't see, if I think about like hemolysis, right? I think about like what's in the environment of the cell, right? That is called what is on the cell surface that causes the red blood cells to burst, and then what's the inside the red blood cells. And off the get-go, I'm curious to hear your thoughts, but I don't have a good feeling of like hemolysis, right? This is like more chronic happening, although chronic hemolysis can happen. You can always like send haptoglobin that is like a little bit more specific, although remember haptoglobin is also acute phase reactant. So and it's made my liver. So any liver disease makes it low. Anything that causes inflammation can cause it to be high. I don't get a flavor of hemolysis in this case. However, this might not be a typical presentation. So at least like you can do the workup. Autoimmune hemolytic anemias are common. MAHAs are your no misdiagnosis. I doubt it. Autoimmune hemolytic anemias can be associated with a whole slew of diseases. So at least like getting a smear to take a look to see like what is the morphology of the RBCs. And if you become more concerned, then I think it's a fair thing to set. The other thing that oftentimes like causes elevated LDH is like some of the indolent infections that can do it. Again, like some of the fungal pathologies, like oftentimes we associate with PJP. Again, less likely in someone who's not non-immunocompromised. So I think my big buckets are like, no, don't miss a hemolysis in this case. Think about whether you're actually dealing with a hematologic malignancy. Professor, how are you thinking about this?
I love that approach, like both like just your reflex and then doing more system two thinking. Yeah, what I think like just looking at that trend, whenever you have bicytopenia with the platelets and the hemoglobins being down, the really you should prioritize the peripheral blood. And if that workup is negative, then you can make your way to the marrow. So like the way it works is that if one cell line is down, it's almost always peripheral blood. If two cell lines are down, it could be peripheral blood or the marrow. If three cell lines are down, it's almost always the marrow. There's exceptions to all of this. And I think when you have thrombocytopenia and anemia, you have to consider a microangiopathic hemolytic anemia. Like it has to be thought about. And so the smear is going to be really important to look for schistocytes, because if that schistocytes are present, then you're in that world of TTP, HUS, but there's other causes like APLS. And TTP, although we're taught it being like, oh, if you don't diagnose it, the patient dies. I've read cases of TTP on and off for months, like very low grade. So I think the smear is important. And then the question becomes, how do we connect the bicytopenia to the headache? And like one way would be TTP, like low grade. But another way would be what what Rahul said in the chat, which is such a phenomenal thought. Like, could this be APLS? And could this patient have a cerebral vein thrombosis? To just give you a little bit, Charmin, of like what happened this morning was that the patient came in with a history of bicuspid aortic valve, status post-repair, had sudden onset chest pain. And everyone was running towards a possible aortic dissection, had family members that died of aortic dissection. Got a CT scan, no aortic dissection, had urinary retention. So now had acute urinary retention and chest pain, but how do you link the two together? I couldn't, but Robbie could. He said, what if you have something in the spinal cord, the thoracic spinal, causing referred pain to the chest and causing urinary retention? And this patient was on anticoagulation and had an epidural hematoma causing both symptoms. The only reason I'm sharing this is I don't want us to neglect the headache. Like that's why she's in the hospital. The CB, right? She can't do that. So now I think we have to try to explain the hematologic abnormality, the bicytopenia, and what seems to be like hemolysis, in addition to what's driving the headache. And I don't know if you have any other thoughts on that, but the only two ways, and I'm doing this in real time, one would be TTP, and the other would be like a clot and APLS. I don't know if the audience has any other ways to link hematologic to headache. I think that's the key to answering this diagnosis, this question.
I love it. I totally agree. I think that is like a great way of thinking about it. APLS was such a smart thought. I didn't think about it. I love it. Yeah. So I love it. Some clots that can explain the both, like in the form of APLS, TTP with hemolysis. And I do think like hematological malignancies can do whatever they want to do. So I think that would be like kind of the third bucket of like trying to link all of these together.
Sharmin, I love that because I've definitely seen leukemia infiltrate the meninges and cause, I've seen that 100%. So I think the bone marrow is not off the hook. Thank you for that.
I have a small request, but Sharmin and Reza sessions should be more frequent than they currently are. This has been such a great, like, especially you guys going back and forth on certain things that one may highlight and the other one doesn't. I'm really enjoying this
Hey,
discussion.
Jazz, you can't make all the insults with.
You like
Oh, I'm
muted
sorry.
yourself.
Did I break up? Oh, I was gonna say you can't make up for all your years of insults with one compliment. We're gonna need way more than that, eh?
Yeah, that's right, eh? Um, Reza, we're both gonna get deported by the amount of Canadian thing references we're making. All right, so I'm gonna make up another aliquot just so we can. This discussion has been really good. So, um, LDH was still elevated at like I said, 396. The next day it was like 402. Haptoglobin was completely normal. A blood smear did not show any schistocytes. Iron studies were normal. MCV was 87, and you know, RDW was like mildly elevated, like 18.6. So I'll give you guys that very preliminary result before I give you the rest of the smear. And then we'll go to the last aliquot, which has the diagnosis.
Sharmin, I really have to pass the mic. The reason I have to pass the mic to you is like I really you were like, I don't think this is hemolysis. And that's where I was leaning towards. So I guess piggybacking off your thinking, if we're not dealing with hemolysis, that really, I think, lessens the likelihood of a peripheral destruction. There's no hemolysis. Haptoglobin is the most sensitive test. And yeah, if someone has cirrhosis, it may be low for that reason. But I think now we got to bring our attention to the marrow. And if our attention is to the marrow, the question becomes on the smear, did Jazz see any was the smear showing any blast cells? And is this the manifestation of an acute leukemia, like an AML picture in this patient? Thoughts on that?
Yeah, I agree. I think like especially with like the LDH, like that is like keep rising, in absence of a better explanation. I would like, yeah, I'm curious what he saw in smear and like maybe a flow, if it can be sent, and then like hematology, bone marrow. I personally think we underutilize bone marrow biopsies. I think they have like a lot of information and a lot of like these progressive diseases you might be able to catch a little bit earlier. So I have become a big proponent of bone marrows. When I cannot really explain why people are like anemic or have like hematologic abnormalities. And I think the other thing that is like notable, and I like your leukemia thought, is that and, like there was no like lymphadenopathy, no other thing on the chest and abdominal pain when I got the chest CT abdomen pelvis. And I think like again it's like worth reviewing sometimes these imaging with a little bit more detail after a new thing is discovered to go back and make sure nothing was missed. I know there's like limitation in the setting Jazz was practicing. So yeah, I agree. I think a hematology consult flow would be really helpful. There are a few lymphomas that don't present with lymphadenopathies as well. So yeah, I'm worried about a hematologic process and malignancy here.
And I'm still so confused by the headache because I was just thinking to myself, if there's leukemic infiltration, that MRI with GAD would show leptomeningeal enhancement. And so I don't know, I can't, I mean, I just don't know how to explain the headache with, unless it's just a bystander and it's just a image negative cause of headache because we just can't see it. But I guess we'll learn momentarily.
Yeah, and I still think like, the thrombosis thought is a good one, Res, because like I think if she's at increased risk of or there's a perineoplastic phenomena that can happen, I think that's a really good thought to get the as you wanted to get the MRV. Because yeah, it might be just like, she's just having such a severe reaction to a secondary, like to a more systemic cause, which is odd, right? Like the degree of the headache is so debilitating. It has to be, have to have a better reason for it. So I think like the plot is so smart. We'll see.
All right, Mark, to answer your question, ferritin was like mildly elevated. It wasn't very impressive. So I think you guys, I think I'll just share what happened with the rest of the course. So I love how you guys both were referencing that I was looking for like the blood smear. I don't even know what the hell I'll be looking at. So I sent off the smear for the pathologist to review while I'm like trying to like think through this problem. I agree with the multiple people in the chat. When I first saw that CT head with this pineal gland cyst, the first thing I thought to myself was, what the hell is a pineal gland cyst? And I've never seen a pineal gland cyst lead to occipital headaches. The location was key here. The occipital headaches did not add up. So I agree with the chat, and I was like, is this an incidentalloma? And then the MRI confirmed that. So basically, I was trying to like get more history from the patient when like around afternoon, around like 3, 4 p.m., the pathologist frantically calls me and says, "Hey, were you the one who ordered the smear?" I'm like, "Yeah." And he's like, "So this patient has hour rods." And I was like, "What?" He goes, "Yeah, like there's hour rods in the cells, and like this patient needs atra immediately." And obviously, being in a rural hospital, they didn't even have like a hematology service, let alone atra. So I'm getting the transfer process started to send her to Rochester General. But then I was like, wait a minute, like, yeah, definitely needs to go, needs to get atra. But for 6 months, for this lady to be an APML does not make sense. So basically, I was still concerned for AML, but she needed to be seen by hematology stats. So she gets diagnosed, she gets transferred, she gets diagnosed. The fish and everything confirms that this was actually acute myelocytic leukemia, specifically NPM1 and FLT3 mutations. So that's just a bunch of gibberish for me. So that's why I looked it up further. And basically, AML has like different genetics and risk stratification. And NPM1 mutation is by far the most commonly mutated gene in AML. In isolation, it actually has a favorable prognostic factor. But because this lady also had the FLT3 mutation, it's basically FMS like tyrosine kinase 3, and it's about 30% of AML cases. But because she had that as well, it just means that there's a higher risk of relapse and worse outcomes, unfortunately. But it's how you can determine if the patient is high risk or intermediate risk or low risk is you look at something called the allelic ratio. And her allelic ratio fell in between the intermediate range. So I guess that's better news than having a high risk for relapse. In terms of certain questions that were brought up to the chat, is what about the headaches? I also, Reza, was concerned for sinus thrombosis. However, when she got to the hospital for induction of chemo, um, her headaches did improve with the chemotherapy. So then they started doing intrathecal chemo because they actually thought this was infiltration into the CNS by leukemia. They ended up not getting in the MRI venous. And my next question, the next teaching point is that the first 3 days of my patients that are in the hospital, I always check a diff. There was no diff on admission, and a leukocytosis of 13.1 could mean so many different things based off the diff. We don't know what that initial diff was. When the smear came back, they updated the diff manually then. But I think the biggest teaching point here was not to anchor so much on the cyst and honestly listen to your patients. She told me that like this is new to me. These are symptoms that basically I've never felt before. And to be honest with you, she on paper, her playlists weren't that bad. And her leukocytosis 13, most people would see that as not a big deal. And after that, when I saw that her inflammatory markers weren't even that impressive, but the LDH was disproportionately elevated, that's when I was concerned for a hematological malignancy. And I think the biggest teaching point I'm going to share now is most of like the patient's perspective. And I saw her 2 weeks after she got induced for chemotherapy. I went into her room. She wasn't there. Her husband was there. And I'm like, hey, where's the patient? And he's like, oh, did you not see her? She's like doing laps around the unit. I was like, oh, okay. I finally see her. She had like this beautiful lust of hair when I first saw her at the real hospital. She's now completely bald. And it took a while for me to recognize her, but she recognized me, and like she came by right away and gave me like the biggest hug. And she goes, like, you saved my life. And I've been very fortunate to be in situations where I've made like incredible calls and stuff like that, but this one freaking took the cake, man. Like, I couldn't help but cry. And she basically was like, I'm like keeping my strength here so I can fight this. And I'll tell you guys that this community, CP Solvers, is what made me who I am today. And, you know, personally, there was someone close to me who also had to battle cancer. And at the time, I was naive. So for this lady to get a second chance because of me, it's special. It's very special. And, it's one of those situations where it's all worth it. At the end of the day, all this hard work we're putting into it's so worth it. Um, and I hope it inspires folks to say that this is not just cases. This is cases that we apply to real life people. So, um, yeah, that's what I'm gonna say.
I don't even know how to. You're making me emotional. I'm about to come there to where do you live, Jazz? What city? I'm joking. I'm joking. Relax. I'm about to come there and give you a big hug and fly out to Canada with you on Air Canada's business class flight to Quebec, which is a province, and where Montreal is located in there. Anyways, Jazz, thank you so much for sharing this case. And if you think about it, like if all your medical training was to save this one life, it would be worth it. All the debt that you're in, all the hours that you put in. And my advice to you is to never forget this case and refer to it when you have moments of doubt, because no, all of us are going to experience medical mistakes. All of us are going to be criticized by colleagues. It's just part of medicine, unfortunately. But all you have to do is reach in your cookie jar and think about this one patient, and you'll be like, wow, my whole career was worth it for this person. So, and I just want to say one more thing before I pass the mic to Charmaine. I also feel honored that you would present this case to us too. Like really, like that you would bring this special case. And I know you didn't do it because it was us two, but I'm gonna perceive it as such. And it just makes me want to hug you more that you trusted us to discuss this case. Charmaine, you're a sharpshooter every time. You just know.
No, no, not at all. But I couldn't agree more, Jazz. You are an amazing human, even a better physician. And I think one of the best mark of a great physician is that they lean in, not lean out. And I think this is a prime example of that, is that the discrepancy of like where her presentation, how she was feeling with the objective data, and instead of being like, it's fine, outpatient follow-up, leaning in to be like, no, 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 there is something going on. And even if it's just like watching her for a few days and like seeing how things evolve. And yeah, we are lucky to have you. You are, and I think it's very kind of you to bring that generosity and say, like, this is also the CP Solvers community, but you make CP Solvers community, CP Solvers special is because people like you. And I'm eternally grateful to you and to all of these amazing physicians that I get to know and learn from in this space. So yeah, I'm feeling very touched, and I think there is nothing better than that hug. Um, when people recognize, we don't do this for the recognition. It didn't matter how she felt, right? But to feel that encouragement and that love from that is just amazing. So thank you, Jazz. I appreciate you and I appreciate everyone here. You guys are the best. This is amazing. I'm so glad she's fighting and she's doing better. This just warms my heart. And Prof. Rez, there's nobody better than you to discuss cases with. Uh, Shout out to Masa for doing scribing and Mina Hill. Mic to you.
Thank you, bringing Jasdeep, for bringing such an incredible case. So first of all, we will discuss about approach to headache. So there are 4 causes discussed by the Reza. So is this primary? We have to consider the migraine, tension, cluster headache. Is there any external exacerbating factor like any facial involvement, like in the acute glaucoma? Are there any systemic causes like fever, or there intracranial causes? It can be tumor, GCA, subarachnoid hemorrhage. Then we study or discuss about the red flags of secondary headache. The mnemonic for that is SNOPE. So it is systemic symptoms, neurologic symptoms, onset is sudden, patient is old age, greater than 50 years, and progressive in nature of the headache. After that, we have to localize the problem systemically, whether it's MSK, any neck pathology is causing this, any CNS, or it's spinal cord related, maybe hematologic, or like cardiac chest pain can present with the neck pain. So we also find that cyst in the MRI, and we have to rule out whether this whether this cyst is causing a headache or this is an incidental finding. And it will be a good approach to also involve neck in the imaging and to do the MRI to evaluate the pattern to rule out, to know what's the underlying cause. But if the MRI turns negative, there can be 2 reasons. Like the threshold to treat for the migraine may be low, or the other cause can be venous sinus thrombosis. Then we have to we can reevaluate the MRI, assess for the intracranial causes, and we have to check is the headache positional, or can we do the LP? Then we study about blood cell deficiencies. If we have the cytopenia, it is mostly peripheral blood involvement. If it's cytopenia, it's first peripheral blood we have to rule out, then we have to move toward the marrow. But if it's pancytopenia, then it's always marrow. If blood smear in this case turn out normal, then we have to move towards the bone marrow evaluation. If we found the blood cells, it will be AML. If you have a lymphadenopathy, it can be lymphoma and leukemia. So this is the end of my teaching points.
Mina Hill, thank you so much. That was so awesome. Thank you all. This is gonna go down as one of my favorites. So thank you, Rez. Thank you, Jazz. Thank you, Masa. Thank you, everybody in chat. You all are so incredible. I wish there was somewhere to capture all of that chat wisdom on YouTube too, you know?
No one needs to inject Mark with a benzo. He's just going off the scales with all his thoughts. And Yusuf had said sickle cell with Moya Moya. Man, what is going on in that chat? Benzos for everyone.
Andrew's like 1-to-1 sitter on Mark.
Yeah, Andrew, put him in restraints, man. Get his hands in restraints.
He can't stop. He won't stop. That's how great his diagnostic reasoning skills are. Oh, y'all are the best. We'll see you tomorrow. Have a great one. Bye.